Right intravenous fluid for resuscitation. Current trend. Both crystalloids and colloids are widely used for fluid resuscitation. But choice of fluids, crystalloid or colloids, is long-lasting debate. Let's see what current trend says. Types of IV fluids. Normal saline versus Ringer lactate, balanced salt solution. Normal saline. Most commonly used crystalloids for resuscitation due to easy availability, low cost, and compatible with co-infusion of blood products. Why normal saline is harmful? Normal saline is neither normal nor physiological. Normal saline differs from balanced fluid Ringer lactate in two regards. 1. It has higher chloride concentration. 2. It does not contain buffer. Normal saline has 154 milliequivalents per liter, supraphysiologic concentration of chloride, that is 50% higher chloride concentration compared to human serum. Infusion of large volume of normal saline can cause hyperchloremic acidosis, higher risk of acute kidney injury, coagulopathy, hyperkalemia, and interstitial fluid retention. Now we will see mechanism of hyperkalemia and acute kidney injury due to normal saline. Mechanism of hyperkalemia due to normal saline. Normal saline has been shown to produce hyperchloremic acidosis, which shifts potassium out of cells, leading to hyperkalemia. So normal saline does not contain potassium and therefore safe fluid in presence of hyperkalemia is a myth. Mechanism of acute kidney injury due to normal saline. Large amount of normal saline administration, which leads to rise in chloride concentration in distal tubules of kidney. Through macula densa, chloride signal transmitted to afferent arterioles, which causes afferent arteriolar vasoconstriction, leading to decrease renal perfusion. This causes decrease in glomerular function rate and acute kidney injury. Colloids. Rationale of using colloids for resuscitation. All colloid solution remains in vascular space, which leads to rapid plasma volume expansion. Faster achievement of hemodynamic goals compared to crystalloid leads to less organ damage and decrease incidence of organ failure. Need less volume to correct hypovolemic shock, which prevents complications associated with large volume of crystalloid, such as hyperchloremic acidosis, dilutional coagulopathy, and tissue edema. Another hypothesis is colloids have longer intravascular half-life, therefore have longer lasting effect. Several large studies and randomized controlled trials does not show any improved outcome with use of colloids. So rationale behind using colloid does not prove. Another colloid, hydroxyethyl starch. Few major trials done, which compared hydroxyethyl starch to crystalloids for resuscitation. Conclusion of trials, there is higher incidence of renal replacement therapy and significantly higher 28 days mortality after hydroxyethyl starch use. Current recommendation for hydroxyethyl starch. Hydroxyethyl starch should be used at lowest effective dose for shortest period of time. It should not be used for more than 24 hours. No longer be used in sepsis, burn or critically ill patients. Hydroxyethyl starch should only be used in treatment of hypovolemia due to acute blood loss. Albumin. Among colloid, albumin is preferred over hydroxyethyl starch. Albumin considered as a second-line agent for fluid resuscitation and can be used in patient unresponsive to crystalloid or those who cannot tolerate large volume crystalloid. Avoid albumin for resuscitation in patient with severe traumatic brain injury. Ringer lactate, balanced salt solution. Balanced crystalloid are more physiological than normal saline. Closely mimics human plasma in its content of electrolyte. The chloride content of RL is 109 milliequivalents per liter. Precursors of bicarbonate such as lactate and acetate in RL are metabolized into bicarbonate and correct metabolic acidosis. Buffering effect is major advantage of Ringer lactate above normal saline. Plasma LYTE. Another balanced crystalloid. Plasma LYTE is isotonic electrolyte solution. 1 liter contains 50 grams of dextrose and contains 140 milliequivalents sodium, 5 milliequivalents potassium, 3 milliequivalents magnesium with a low chloride level of 98 milliequivalents. Plasma LYTE is preferred solution in metabolic acidosis in critically ill patient and diabetes. Major liver surgery, liver and renal transplantation. Major open GI surgery. Neurosurgery with critical brain injury and complex cardiac surgeries. Conclusion or current recommendations. Isotonic balanced salt solutions use as first-line resuscitation fluid. RL is recommended in diarrhea, surgical patients, trauma, burns and when large volume of fluid required for resuscitation. Avoid RL for resuscitation in patients with severe metabolic alkalosis and hypochloremia, for example profound vomiting. Lactic acidosis with decreased lactate clearance and in patients with traumatic brain damage or patients at risk of increased intracranial pressure. Balanced crystalloid, that is RL, contains small amount of potassium. Risk of hyperkalemia is significantly less compared to normal saline. RL should not be given with blood products because calcium in RL can precipitate with citrate in blood transfusion. Infusion of large quantity, that is more than 2 liters, of normal saline can cause hyperchloremic acidosis, acute kidney injury, coagulopathy and hyperkalemia. Normal saline is fluid of choice in patients with hypovolemia due to vomiting or upper GI suction. In metabolic alkalosis, traumatic brain damage and along with blood products. Normal saline should be used with caution in patients with increased risk of acute kidney injury. Small to moderate amount, that is less than 2 liters, of NS does not increase the incidence of AKI. IV fluids are very commonly used in hospital wards. Doctors and nursing staff must know its proper indications. I hope this video will definitely help medical health professionals. Thanks for watching. Do not forget to subscribe the channel.